We're going to start moving on to glomerulonephritis. This is a form of intrarenal failure. Okay, remember this is dealing with the tissue itself of the kidney. Therefore, it's going to be an intrarenal cause of those acute renal failures. So there's a spectrum of glomerular diseases. On one side, we have nephrotic. Remember, it's got the O. So proteins is more on this side. Injury to the podocytes is the main mechanism for this type of injury. Remember, the podocytes provide the fenestration size around the outside, preventing large molecules from getting through. As you destroy those podocytes, the opening gets bigger and the bigger molecules can get through. So you see here the proteinuria side. We have one disease called minimal change disease. We're going to talk about membranous nephropathy. Here's your diabetic nephropathy. Still on the proteinuria side. On the other end of the spectrum, we have the nephritic side. Okay, the mechanism for this, inflammation. Breaks in the glomerular basement membrane. And the other thing that you see is this thing called crescent formation. We'll talk about crescent shapes in a minute, but basically you'll see what happens. You can kind of see a little bit of these little crescent shapes here. Oh, I'll highlight that. Well, the highlight's big, but anyway, in those highlighted areas, I'll erase those, are the crescent shapes. And we'll have pictures later on that describe that more. So on the nephritic side, we have this anti-GBM disease. It's anti-GBM, anti-glomerular basement membrane, so obviously it's going to attack that basement membrane, and that causes the nephritic syndrome. Small vessel disease, post-streptococcal glomerulonephritis is here. But you see as you start going in the middle, you get a mix of protein and blood on those middle ones. So don't forget, as we go through these diseases, some of them are a mix of both, some of them are just one side or the other. So glomerulonephritis is a type of nephritic syndrome. Immune complex disease formation gets deposited here, infection, often results in hematuria. Why hematuria? What's nephritic disease? Yeah, so blood cells are getting into the urine. So you're going to have hematuria because blood cells are getting into the tubes and they're going to come out later in the urine. What disorders have been linked? Here we go. Several diseases may be caused by diseases specific to the kidney or from systemic disease with kidney involvement. So things that happen elsewhere in the body, but their effects happen inside the kidney, causing changes in there. They're going to present with some combination, hematuria, proteinuria, but very, very small amounts. This is nephritic syndrome, so majority of it's going to be red blood cells, but you may see some small amounts of proteinuria, reduced GFR, and hypertension. The categories, you can have the acute form, and that resolves within weeks. There's rapidly progressive glomerulonephritis, and then there's chronic glomerulonephritis as well. So some causes, here's your antigen-antibody complex. What type of reaction is that? Yep, okay, immune complex. And then obviously here's your other things there. Facial periorbital edema they may get. Oops. Why? Why do they get swelling? What's going on in the blood or in the urine? What are we losing in the urine? Small amounts. Protein. So if we're losing protein in the urine, where is it not? In the blood. If we don't have any protein in the blood, what type of pressure is being reduced? Oncotic pressure. Oncotic pressure is the push or the suck. The suck. So the suck goes down. So where's the fluid going to go? Interstitial space. And they give you the periorbital edema and swelling with loss of protein. You'll see it much more severe with the nephrotic syndromes when we get to those. So acute glomerulonephritis has an infection there, so you have to ask about recent illnesses. Were they sick recently? What was going on? Some examples: post-streptococcal group A beta hemolytic strep. So when you're studying things, some diseases go with group A, some go with group B strep. So as you're studying, make sure you know, is this a group A strep or group B strep? Pneumococcal pneumonia and sepsis. Abrupt onset, about 7 to 10 days after the onset of the infection. They're going to get hematuria. What's the difference between microscopic and gross? What? You can see it. If it's microscopic, that means you can't see the blood in the urine if you just looked at it. If it's gross hematuria, you look at the urine, it's looking pink, or you'll see blood in there, red blood cells. That's what microscopic versus gross hematuria means. You actually see it with your eyes versus you need a microscope to look at it. Again, small amount of proteinuria, decreased GFR, all those glomerular sites are being destroyed. They're not going to filter properly. You're going to have problems with your GFR due to that. Therefore, results in azotemia and renal sodium and water retention. So, what is going on with acute glomerulonephritis? Antigen and the infecting organism. So there's a reaction between the antigen and the infecting organisms. We activate inflammatory cells, and those infiltrate the glomerular walls, and they create those antibody-antigen complexes. And they get deposited inside. When that happens, neutrophil monocytes get attracted to the area. Lysosomal enzymes, remember all those lysosomes, they break up stuff. Start breaking up the glomerular walls, that basement membrane, and making the end result is a more permeable membrane, but we don't want that to happen because we're losing protein and red blood cells that we don't want to lose. They shouldn't be in the urine. Angiotensin and leukotrienes contract the mesangial cells. Remember those mesangial cells are in between where the capillaries and the Bowman's capsule and that free space in between, that's where those mesangial cells are. When they get contracted, decrease glomerular capillary perfusion. What happens to your GFR when that happens? Less perfusion, GFR drops. Bowman's space may be damaged by fibrin and a crescent formation. The decrease in GFR, distal tubule water, and sodium resorption all leads to fluid retention as well. So we're not filtering out anything. We're stuck in the blood, and we get some fluid retention. What's that going to do to your hydrostatic pressure? Increased hydrostatic pressure, and that hydrostatic pressure is going to cause what to occur? Edema and swelling. Hydrostatic pressure goes up, it's going to push fluid out, and you get swelling. Water sodium resorption, increase the vascular extracellular fluid volume, and because we've destroyed that basement membrane, red blood cells can now pass into the glomerulus, and we're going to get hematuria and red blood cell casts. We talked about casts yesterday. So the cast is because these red blood cells are now in the tubes, and they start to clump up and they make a cast, and that's what that is right there. And it's formed because it's the shape of the tube that it got squeezed through. So you'll see these red blood cell casts with acute glomerulonephritis. So this is a really good picture. They look at different things with and where they're having their problems. So this first part, is looking at anti-GBM glomerulonephritis. Okay, anti-GBM causes binding in situ to the basement membrane antigens. So what's going on? Where this immune complex are being deposited. So you can see all the C, the complement. They're lining up. And they're depositing all along the basement membrane. Okay, so that's anti-GBM glomerulonephritis. You're attacking the basement membrane. Those are the antigen. The complement gets in the area, deposits along the basement membrane, and causes red blood cells to leak out. Immune complex glomerulonephritis. Those immune complexes get deposited, and they recruit cells. There's your antibody-antigen complex. And now they start creeping inside into the walls. You see along the basement membrane, they're getting in there. Okay? So this is immune complex glomerulonephritis. And this last one is ANCA, and ANCA means anti-neutrophil cytoplasmic antibodies. You're going to get this a lot when you get to room with Dr. Ovalle next year. But glomerulonephritis attacks, these are the ANCAs right there. They attack that cell and causes problems with the, again, basement membrane. Whenever you see nephritis, it's attacking the basement membrane. Remember, nephrotic syndromes, the O, the protein one, is the podocytes. And that's where the damage occurs to make that wall more permeable to let proteins leak out and red blood cells. So, signs and symptoms for acute glomerulonephritis. Gross hematuria. There's that coffee-colored urine. Okay. Smoky urine. Red blood cell casts is a classic indicator for acute glomerulonephritis. You may have some white blood cell casts. Proteinuria may be there as well, and that's going to lead to that periorbital edema because of the protein loss in the blood. The protein's all going into the urine. So all of these are all due to protein loss. Periorbital edema, lower extremity edema, ascites, pleural effusion. Those are all due to hematuria. You're losing the protein out of the blood. Your oncotic pressure is reduced, so we get all this swelling going on. Arterial diastolic hypertension from the excess fluid volume that's going on in the body. Remember, the fluid volume dictates your diastolic pressure. When you get dehydrated, that vascular volume starts to drop. Your diastolic is going to drop as well. High cardiac output, high peripheral vascular resistance, because we have a lot of volume in the system, the pressure goes up. Okay, and this is all due to acute glomerulonephritis. The next one we'll talk about is rapidly progressive glomerulonephritis. You may see it also as RPGN. Similar to vasculitis. I did a site visit this morning with one of our students. We do them on rotations 1 and 7. So next year when you guys go on rotations, all of us will come visit you on your rotation during rotation 1 and see how you're doing and whatnot. So I went and saw one today, and she's working in derm. And she's like, yeah, yesterday we saw a patient with vasculitis, and they had the palpable purpur and everything, and they could feel it all, and you see it. So there you go. So there's vasculitis with rapidly progressive GN. Kidney function is lost within weeks or months. Relatively uncommon. Age range between 20 and 50. There's 4 categories of this one. Either it's due to a underlying infection, post-strep infective endocarditis, or multi-system disease. Here's your lupus. Remember, lupus is a multi-system disease depending on wherever those immune complexes get deposited. We've been talking about immune complexes a lot in this part, at least for the nephritic syndromes. And that's an example of how a system disease can affect. It's not a kidney disease, it's a systematic disease that affects the kidneys. Drug exposure and then idiopathic, we don't know why it happens. So they get a lot of these crescent formations. And the crescent is, let me change the color, is right here. That's the crescent shape, caused by fibrin. Okay. So obviously this is on histology, so you have to do a renal biopsy to find these things out. You can't do anything otherwise. You need a renal biopsy to get the tissue and see what's going on. If untreated, remember those are always the big ones, it's going to progress to end-stage renal disease over weeks to months. So they're going to be put on dialysis later in life if you don't treat it. The severity of the disease is in part related to the degree of the crescent formation. So the more crescents you see, the more severe that disease is for that patient. And you classify it based on immunofluorescence microscopy. The next one is chronic glomerulonephritis. Okay, continuing or persistent hematuria and proteinuria, and slowly progressive deterioration in your renal function. Can be lasting for 10 to 20 years. That's why it's chronic. Remember, there's acute ones. Within weeks to months, they occur. And even the acute form, 7 to 10 days after exposure to a pathogen. Chronic takes a very, very, very long time to occur. The end result with chronic glomerulonephritis, hypertension, contracted, scarred kidneys, and renal failure. Makes sense. You're destroying the kidneys. They're not going to work as well anymore. Because they're not working as well, you're building up in fluid, which is going to cause hypertension. That's why they have hypertension later on. And the kidneys are just scarred from all the years of abuse from their disease. So what's going on here? Again, antigen-antibody complexes, or it's that anti-GBM, where these immune complexes attack the glomerular basement membrane, as in the acute form. The structural hallmark for chronic is cellular proliferation, either in the mesangium or in the capillaries. And I don't know why that's black. Why are we blocking out here? Let's go back. Okay. Okay, so looking at, again, chronic glomerulonephritis, signs and symptoms, hematuria, proteinuria, the scarring is big. Remember the scarring. When you scar something, that function is lost. It's never coming back. The more scarring you have, the more loss of function you get with your kidneys. Edema, fluid volume, and hypertension. Okay, so these are your signs and symptoms of chronic glomerulonephritis. Now let's talk about nephrotic syndrome. That is what periorbital edema is due to hematuria. Okay, you're losing oncotic pressure. Look how swollen those eyes are. If you ever see a child like this, there are two things to think of immediately. One is what? If you saw a face like that, what would you think happened? Allergic reaction. And if it's not that, think nephrotic syndrome, especially in kids. Kids should not have that much swelling going on, that puffiness, usually an underlying disease. So, okay, collection of symptoms caused by, again, glomerular disease. Again, intrarenal, we're messing up the tissue of the kidneys. Large amounts of protein loss in the urine, 3.5 grams per day of protein. It's a lot of protein. Again, increased glomerular capillary permeability because we lose those podocytes. So the bigger molecules can get through. And proteinuria causes the nephrotic syndrome. Signs and symptoms: edema, okay, no protein to draw fluid back into the blood. We lost our oncotic pressure, the suck is gone. Hypoalbuminemia, okay, whatever the liver's trying to make to bring up your protein, you're losing it right out of the urine anyway. So that's why you have hypoalbuminemia. We're trying to make more proteins, but as you're making them, you're going to lose them out of the urine. And that leads to the hyperlipidemia. The liver is trying to make proteins, and it makes cholesterol as well, so your cholesterol levels go up because the liver is working hard to get all that stuff going. Because the liver is making all these extra lipids, you get lipiduria. Okay, fats in the urine. And if you, the way you can tell this is on when you go to the bathroom and they urinate, you'll see like oil slicks, like stuff floating in the urine. That's the fat. That's that frothy, foamy appearance to the urine. Hypercoagulability. Why are they in a hypercoagulable state? Well, if the liver is working hard to produce proteins and to produce cholesterol, what else does the liver produce? Clotting factors, right? So you produce a lot of clotting factors too. So all these clotting factors are floating around that shouldn't be there, but they're there now because the liver's working overtime because you have nephrotic syndrome. Those coagulation proteins are going to go up as well, putting you into a hypercoagulable state. So if something were to trigger a clot to form, it would be in excess and you'd have a massive clot forming. So they're in a hypercoagulable state and obviously altered immunity. They got a problem with their immunity as well. Usually resolves spontaneously, but it can progress to end-stage renal disease. It is related to 6 disorders. So nephrotic syndrome is like an umbrella term again, and it relates to minimal change disease, which is the most common case in pediatric cases, called minimal change disease. Minimal change because there's minimal changes in the tissue that occur. Focal segmental glomerulosclerosis, there's a bunch of them. These are secondary because they're due to systematic causes. So like diabetes is a disease that affects the kidneys. So the nephrotic syndrome will be secondary to the diabetes. That makes sense? They would not have nephrotic syndrome if they didn't have diabetes first. That caused that to happen. So in this case, permeability of the glomerular wall is increased. Basement membrane, those foot processes will allow proteins to pass through. This causes a decreased oncotic pressure. Therefore, the hydrostatic pressure wins, and we get third spacing of the fluid, meaning it's going into that interstitial space. Yes?
So with the nephrotic and the nephritic syndromes, it's basically like they both have issues with the podocytes and the basement membrane.
Yes.
It's just that with the nephrotic, it's just more protein that they're losing.
Mm-hmm. So remember on, let's go back to this picture. So we're dealing with this side of things. So your minimal change, membranous nephropathy, here's your diabetic nephropathy. Those are on the more on the protein side. You do have ones in the middle, like lupus, can be any range. That's why lupus is so weird. It could be nephritic or it could be nephrotic, or a mixture. Because remember, it's just depending on where those immune complexes go. Yes?
Why do we see it more in kids?
I don't know exactly why it's in kids. Maybe there's some issue, but it's called minimal change in kids because not much structural changes go on. That's why it resolves spontaneously. As far as what causes it, I'm not exactly sure. Okay. Yeah.
So they both affect the podocytes and the basement membrane?
Which one?
Both of them? Or is it just the nephrotic?
Nephrotic. If it's a nephrotic syndrome, it's going to be more on the protein side. More protein loss than anything.
And what's affected? Both things? The basement membrane and the...
No, if it's nephrotic syndrome, it's just the podocytes.
Okay.
Just podocytes.
And more protein loss.
And protein loss. If it's nephritic, it's going to be glomerular basement membrane damage with red blood cells. Okay, so we have increased hydrostatic pressure. Because our renal blood flow is going down, our RAS system is activated, which causes more protein loss and edema. Hyperlipidemia is there. Obviously, we have a lot of liver activity, so they're going to be producing a lot of that stuff. Normal cholesterol can be over 200. With these patients, it could be 600 to 700 for cholesterol. Massively high. The liver is producing cholesterol. And then lipiduria, so you will see, or you could see, lipid cast or fat droplets in the urine. Okay, all that protein goes into the tubes, and just like a red blood cell cast, the fat cells can do it as well, your lipid molecules. And they can create a cast that you'll see on microscopy with the urine. Hypercoagulability, again, alter levels of clotting factors, so we know they're producing a lot. Those clotting factors are going to go up as well, so be careful for that. So glomerular damage occurs. We have increased permeability of the proteins, leads to proteinuria. Remember that 3.5 number. Okay? This is in a 24-hour collection. So guess what you have to tell your patients to do for 24 hours? Pee in a jug, not in a cup. You gotta fill it up. Pour it in, yeah. And you gotta store it in the fridge. So you don't mistake that with the apple juice, but it's there. So they gotta collect it for 24 hours, bring it back to the lab, and then they test it for how much protein's in it for 24 hours. What other tests do we do for urine for 24 hours that we learned about? What? Cortisol? We do it at 8:30 in the morning, but what test do we do for 24-hour collection of urine? And remember? We talked about pheochromocytomas, that tumor in the adrenal medulla that dumps out a lot of catecholamines. So we do a 24-hour urine collection to see what's going on. So hyperproteinemia, lack of blood proteins, and obviously as you go through, loss of oncotic pressure leads to edema, and we get hyperlipidemia because of the liver working overtime to put out more proteins. And here's a good summary slide between nephritic and nephrotic syndromes. Again, this guy went to school here. You see his picture out in all the school classes. So he makes all these comics and the whole book. Yeah, he's from here. If you notice that you go to the bathrooms, that the brachial plexus tree that's out there, he drew that, and same guy. So, okay, I think he graduated in like 2011, 2012, I think. Okay, moving on finally to the last section for today is renal stones, kidney stones. So, they both make stones, but one you got to get rid of, the other one you can keep. Okay, so flank pain that may radiate to the groin. That's why you do CVA tenderness, looking for any type of irritation in the kidney, some sensitivity. They're going to have hematuria because as that crystal is moving down the tubes, it's scraping along the urethra or the ureters and causing damage. That's going to spill some blood. They may present with a complete obstruction or decreased or absent urine flow. So either it be a partial obstruction where you can still make a little bit of urine or get rid of it, or it's a complete obstruction and no urine can pass that, and it starts working its way back up into the kidneys. An obstruction can occur at any of these locations, and you do a CT scan and you'll be able to see where these stones are and what to do with them. Etiology, 75% of stones contain calcium. So calcium is the big one that causes a lot of these stones to form. Most are due to idiopathic hypercalciuria. What's that? Hypercalciuria. A lot of calcium in the urine. You guys remember doing that experiment when you were like in school as a kid and you put that string in like sugar water and then the sugar would precipitate out and crystallize? That's what calcium is doing here. There's too much calcium in the urine and it precipitates out into a stone. It crystallizes, essentially, and that's what causes the stones to form. We also have uric acid stones, and that is with gout, and we're going to learn about gout next when we do musculoskeletal. But uric acid is another form of kidney stones. It has to do with purine intake. We'll talk about foods that are very high in purine. Could also be due to a defective amino acid transport, and that would result in cystinuria And the last one, it could be our struvite stones. Struvite stones can either be bound to magnesium, ammonium, or phosphate due to chronic UTI, but these urease-producing organisms. So you can also have another type of stone, magnesium, ammonium, or phosphate. But the majority of them are going to be calcium. Dehydration favors stone formation. Okay, if you're removing the solvent from a solution, the solutes start to build up. It's like if you ever take a pot of water and you boil it all the way out and you get rid of all the water, you're going to see a ring of dust on the bottom, which is remaining solutes that were left. That's what's going on here. Severe dehydration, less urine production, all those crystals inside start building up in concentration, and eventually they hit a saturation point and they crystallize out. It's like if you ever put too much sugar in your coffee, eventually the sugar won't dissolve anymore because you've saturated that coffee with sugar. Anything extra comes out. Same thing here with these calcium stones. High protein diet can also lead some people into getting stones. High sodium diet will predispose to calcium excretion, therefore calcium oxalate stone formation. Which is why we have to be very careful with diuretics. What diuretic affects calcium? Caroline, you love this one. Thiazide diuretics. Thiazides affect calcium as well. So on thiazide diuretics, you can get calcium stones. Also, these factors are protective against stone formation. Fluids, citrate, it's a chelating calcium in solution. So chelators take things out of the solution, bind it to something else so that you can get rid of it. That's what chelation is. Sometimes for certain conditions later on, you'll learn about chelation therapy, where they give you a drug that is going to take that substance, bind to it, and then you can excrete that and get rid of it. Yes?
How fast can diets lead to the formation of stones?
Diets takes a long time. It's got to build up in quantities over time. It's not an acute thing. Magnesium and dietary fiber. Magnesium, be very careful with magnesium. You make sure you know what it's bound to in the preparation. There are different forms of magnesium. One of them will make you go to the bathroom very violently, and we give it for bowel prep. Okay, one of them helps with sleep, but if you take the wrong one, you know what's going to happen. And then dietary fiber also helps as well. Clinical manifestations, they get pain is the big one due to distension of the ureter, renal pelvis, or the renal capsule. The severity of the pain related to the degree of distension. So this one does matter. The more pain they're experiencing, the more severe that lodged crystal is. You get anuria because urine can't pass that stone depending on where that stone is lodged. If that stone is lodged in the urethra, then it doesn't matter. The bladder can't drain. If it's lodged in the left ureter, you're still going to produce urine because the right side is normal and it can still flow normally into the bladder. So you have to know where the obstruction is located. If it's in the urethra and it's blocked, you're not making any urine, you can't get past. But if it's in the ureters, you potentially can get around. All of the symptoms are self-limited. They usually just go away spontaneously. If they don't, then you need to do that ultrasound therapy. They put you in a bathtub and they send shock waves through. You don't feel anything, but it's all ultrasound. And it blasts those stones up, or Thunder Mountain, whatever you want to go. But usually what they have to do for these smaller stones, those of you who work in the hospital, they usually will put a basin, like a filter, in the toilets so that when you pee, they want to see if the stone came out. They'll test it. So sometimes if you get chronic kidney stones, they'll want you to screen your pee to see what the stones are, to see if you can catch them, to see what they're made of. Major complications with kidney stones. Hydronephrosis, just water on the kidney. The urine can't go down into the bladder for storage, and it works its way back up onto the kidney. can cause permanent renal damage. And again, backup of urine and pressure buildup in the kidneys. You can also get an infection or abscess behind that obstruction, renal damage due to repeated kidney stones, and you may get hypertension from increased renin production due to that blocked or obstructed kidney as well. Okay, let's take a break, come back at 10:50, and we'll start musculoskeletal. Caroline, the PDF is already there for you, so you're good.